I'm going to talk specifically today about how to manage a STEMI at the Glenfield, which I think is a really key thing for anybody who's newly joined us to actually know what we need to do specific to working here. And I'm also going to talk about the complications to look out for following a STEMI. And with that, I'm going to talk about complications that can happen to patients attending the cath lab because, it's really you're going to be first in line assessing these patients. So it's very helpful for you and potentially very, very beneficial for our patients if you spot things and know what to do and how to involve people quickly. So welcome to Glenfield, and let's get on with this talk. Just a few quick things before we actually get to the case. Um, this, as I've said, this meetings every week. I do it via Teams because we're not really supposed to meet in person in numbers, and I will hope to at some point when COVID numbers decrease start doing this in person again because it is quite nice to do it with everyone. I do try and get started as promptly as possible at 1 o'clock because I appreciate there's nothing worse than logging on at 1 o'clock and then waiting 10 minutes for somebody to actually get started. So I do try and start absolutely on the dot at 1 o'clock, and we will be done by 2 and hopefully a bit before then. So you're sure you've got a busy day ahead of you. I do email everyone a reminder and post on the WhatsApp group. And if you're not on the WhatsApp group, I showed you a QR code a second ago. This just point your phone camera at that QR code and it'll welcome you to the cardiology group. Your emails might go through to junk mail. If you don't want to receive the emails, just reply saying you don't want them. That's absolutely fine. Don't want to send you mails that aren't useful. If you want me to send it to a different email address, again, just send me the different email address and I'll add it to my address book. It's always the same link. So I use the same link for every single teaching, which is here. And that's a QR code to give you that link into your phone if you need it. And at the end of the presentation, I will post a link for attendance certificate, which just asks a few very quick feedbacks questions. They're really useful for me. I like doing this, and it only works if it's beneficial to you. So please, help me direct my energies to what is most useful for you, with a quick little bit of feedback, and then you get a certificate to say you've attended each teaching. I'll post that link at the end. That link is in the email that I've sent round. So you're welcome to watch lectures on the YouTube channel and then retrospectively get your certificate of attendance for them. So long as you've done watch the presentation, you're very welcome to do that. So welcome everybody who's joining me. I'm just doing a little bit of preamble, and we'll get on with the case. So please interact with me. It's so much more fun if you do. Have more than one computer screen in front of me so I can see my slides and I can see the meeting chat and I can see lots of blank initials where your faces are, and it's quite hard for me not getting any emotional feedback from you. So it's really nice if you post things in the chat to answer the questions. If you want to unmute and speak, you're very welcome to do that as well, but I find people tend to like to type things in the chat. So this is a case, Mr. MI giving you a subtle hint there, and he's a gentleman who really has all the known risk factors, and he treats his health like a gladiatorial contest. And he's presenting to the clinical decisions unit with central chest pain, which has been lasting for 6 hours. Doesn't have any past medical history of note, and he doesn't take any medications. So does anybody want to suggest what they think might be going on with this gentleman? So type in the chat or unmute yourselves and speak, whatever works for you. Yes. Absolutely. So very good. So we're thinking acute coronary syndromes, we're thinking MI, we're thinking excellent GRD, so gastroesophageal reflux disease, pulmonary embolism. PTX, what's PTX stand for? Um, so yes, absolutely. Lots of good suggestions there. So I'm setting this up pneumothorax. Thank you very much. So yes, all of those absolutely. He's obviously there are some factors here that might make us think more cardiac pain. There are some factors about the pain that might make us think other things. I'll do a talk on that another time because I think that it's worth a full talk to really go into the nitty gritty of different types of ischemic presentation. But in the interest of what we're after today, of how to manage a STEMI and complications, let's not go into a great deal of detail about the differential. But one point I do want to make is the pain has been present for 6 hours. So if this patient's troponin is negative, do you think that this is likely to be cardiac chest pain? So, yeah, that's my question. Could this be unstable angina with 6 hours of central chest pain? And the point I want to make here is that it's if you have chest pain for more than 15 minutes, you would really expect it to be associated with a troponin release if it's ischemic. And if you have unstable angina, so you have a ruptured plaque, which is getting more or less blood clot on it, so is causing variable obstruction of the coronary artery, you would expect that to cause some sort of troponin release, either with downstream damage or if the pain has been there for 6 hours because that clot is enough to be blocking flow down the artery, you would expect a troponin release. So all things are possible. This is a very high risk patient. You would have to be wary of not involving your seniors with him. So by all means have a high index of suspicion with all these risk factors. But if it's been going for 6 hours and his troponin is not positive, then we would be thinking this is non-cardiac pain. If he's had 6 hours of pain and throughout that time it's been crescendoing and it's been virtually pain-free at times, or he had a maybe had a very severe episode 6 hours ago and then he's been virtually pain-free but just had a slight residual ache in his chest, we need to get the description of this more accurately. Maybe he had mild pain on and off for 6 hours and then a very severe pain 5 minutes ago. Your troponin's then not going to be helpful because the most severe pain was less than 2 hours ago. But if his troponin is negative, you would be taken away from thinking that this was an acute coronary syndrome. So this is likely to be an ACS, and it's likely to be an MI part of the ACS. So either a STEMI or an NSTEMI. Good. So as it happens, his troponin is positive. His troponin is 400. And so he's seen by the admissions team. He's decided that he should have a coronary angiogram plus or minus intervention. That's how we write down coronary angiogram. And we sometimes write query proceed or plus or minus to say that we're not sure if we're just going to take pictures or we're going to unblock something. And what do you think of that troponin of 400? Is that a high, low, borderline? What does it tell you? Yeah, so it's high. You need to think about kidney function. Absolutely. We should check renal function and we could do a serial troponins if we had renal impairment to see if it was stable or going down or up for that matter. A troponin of 400 with renal failure is possible, but it's fairly unusual. And I think here it is above normal, but it shows a trivial amount of damage. So you could have a troponin of 400, some of my patients do, every day, all year, and not have it significantly affect cardiac function. Some of my patients with hypertrophic cardiomyopathy always have troponin values of around 400. So this is a trivial amount of damage, but it is abnormal. So this very strongly points us towards this gentleman has now had an STEMI, we believe, although there are other causes of elevated troponin. And so we need to investigate this further. But very little damage has happened. We don't really need to do serial troponins in this instance unless we think that actually a lot of damage has happened in the last couple of hours, in which case the troponin might not reflect what's going on. So imagine you're called to see him and the patient is having recurrent chest pain. So he came in with 6 hours of pain. The pain settled down. A few hours later, you're called to go and see him because just after the admissions team have gone off their shift, he's developed further chest pain. So how would you approach this? Imagine you're on the clinical decisions unit. You've just started your shift. You've been asked to go and see this gentleman. What are you going to do? Okay, we could give him some morphine. Yeah, it's very important to holistically care for your patients and make sure that they're comfortable. Um, so Sajad, full A to E, repeat ECG troponin, give GTN. Um, Suzanne, review OBS, quick history exam, repeat ECG, repeat troponin. Good, so lots of nice suggestions. You, in answering this question, the answer is always A, B, C. And that I just would say in this instance, I mean, it's such a useful thing to do your ABCs, and it helps you to be able to do something that's vaguely useful and mask the fact that you're panicking a bit. It gives you moments to think about what else you might need to be doing. The fact that he's complaining of chest pain, you can be pretty sure that he's got an airway and he's breathing and that he's got circulation. Um, and you could certainly examine him, but you'll be able to see the moment you look at him how desperately unwell he might be. And if you think that the patient's peri-arrest, then maybe doing the OBS is good. But here, the real number one essential thing that we want before we really do anything else is an ECG, because assuming the patient has an airway and is breathing, the number one thing we need to know is he having something that will take him to the cath lab? Is he having a STEMI or new ischemia on his ECG? So we need to immediately do an ECG, and really anything other than that is irrelevant. We don't need to know if this pain is cardiac sounding or not. Who cares? He's had a troponin of 400. He's had more chest pain. We just need to have an ECG so we know if we need to be excited or not. So this is his ECG. What does everybody make of this ECG? What do you think? I've been talking over it for a while, so you've had time to chew on this. Is anybody brave enough to say what they think of this ECG? So normal sinus rhythm with ST elevation in 1 and V6. Yeah, I think that's a very good description of it. Does anybody want to add anything to that? Yeah, the T waves are a bit odd, aren't they? Um, can you see how we got some baseline wander in 1? And that makes that look quite elevated. But if we look at the next beat along, maybe there's half a millimeter, third of a millimeter of elevation. It's very, very subtle if it's there. There's no depression anyway, no reciprocal change here. Over in the lateral leads, yes, V6 looks a bit elevated. I think the baseline's fairly flat there, so I'd agree with that. I think it's maybe slightly up in V5 as well, maybe V4. But actually knowing if that's ischemic or not, it doesn't really look much like a STEMI, does it? These T waves in V2, V3 are a bit peaky, aren't they? That does look in V4 as well. That is slightly odd, isn't it? What would you do next? Yeah, we could check the potassium. Absolutely. But this patient's complaining of chest pain. He's, really, he's in quite a lot of pain in front of you. He's looking a bit sweaty as well, and he's got this ECG. What are you going to do about that? You've given him some morphine because, it's very important to address the discomfort of patients. So analgesia then discuss with the SPR. Yeah, so absolutely, you could discuss with the SPR. You will not do wrong to involve a senior in this sort of person where you're not quite sure what's going on. We could load with aspirin. He'll have already been given the aspirin and ticagrelor by the admission team, though, so you could check that he's been given the right stuff. But what are you going to do next? You want to come to a diagnosis here. How are you going to get there? We could repeat the troponin, but that's going to take us a while. So we'll know what we should have diagnosed now in an hour or two, but really we want to do something immediately. So it's a good suggestion to repeat the troponin, but actually we want to do something now. If this guy, we think he's probably got ischemic pain, so we need something immediately that's going to give us an answer. Well, what is that? So the answer is look at his previous ECGs. Because is this a dynamic change from the previous ECGs? We've said that this doesn't look quite right in the lateral leads, but it probably isn't really anything. I wouldn't really remark too much about this. I would be quite concerned about these T waves. I'd be concerned maybe those are hyperacute T waves that are one of the earliest signs of an infarct before an anterior STEMI, before you get the ST elevation. So I would be quite concerned about these, but it wouldn't surprise me if you pass this ECG as being within normal limits. It's really very difficult one. But if you can look at a previous one and see that these are dynamic, different, definitely different from his admission, then you've really got something to be excited about and saying this is ischemia. And it's critically important to look at all the ECGs because things do get missed. And this was this patient's ambulance ECG. What does that show? So it shows extensive anterolateral myocardial infarction. So we've got about 6 millimeters of widespread anterior ST elevation and extensive elevation inferiorly. So this is a big, big infarct. And you'd be astonished that something like this could be missed. And, that wasn't in this case. But every year we have missed STEMIs arriving on CDU that there was no doubt looking at the ECGs, it was a STEMI. Humans miss things. They miss things if they're not expecting them. They miss things because they're human. And when we miss things, we want to have a look at the processes to try and improve them, but it will, I think, carry on happening. And you might be the first person to spot this, and you will only be the first person to spot this if you look at the ambulance crew ECG. And often, because it's printed on bog roll and it's disappears in the bottom of the notes, or somebody staples through it or puts a hole through it, and it's incredibly hard to get the thing out of the notes to actually have a look at. Often people don't, and they might have a dozen ambulance crew ECGs. Look at them all. They get the patients when they're hotter than we do. So if there's going to be an ischemic ECG, it's more likely than not going to be the ambulance crew ECG. And this is an example of a patient who had a big anterior STEMI, anterior inferior STEMI going on his ambulance crew ECG. And then you see this is a while ago. This is actually a patient I looked after quite a long while ago. But this ECG was done the moment that the patient arrived and showed that it all resolved. And just because they're having a STEMI and they don't have a treatment for it doesn't mean it can't spontaneously reperfuse. And this is good because it means that a lot of damage has been saved by the patient spontaneously unblocking their artery. But the fact that this patient has developed further chest pain, and just the fact that such a big territory is threatened, it's critical that we get this patient to the lab and get this sorted out as quickly as possible. So you want to do serial ECGs on this patient, but most important of all, you want to look at the ECGs that have already been done, particularly the ambulance crew ones, to see if they're dynamic changes. Now, let's say that you find this ECG in the notes. You've got this patient in front of you. You're on your evening shift. It's what, 8 o'clock in the evening. What do you do? So imagine that this evening at 8 o'clock, you find this patient. What are you going to do? So there is one simple answer I want from you. So you're going to bleep the card SPR? Nope. STEMI alert. Yes. The only thing you want to do now is a STEMI alert. Don't pass go. Don't do anything else. Pick up the switchboard. Pick up the phone. Dial twos to get through to switchboard as an emergency, and say STEMI alert, and then the location you're at. That will alert the on-call team. It will alert the cath lab coordinator if it's in hours. It will alert the cardiology registrar, and it will tell them that they need to drop anything that they're doing, assuming it can be dropped, and come charging to wherever you are to sort the patient out. And if you're not sure about it, put out a STEMI alert. We would far rather that there's a false alarm and we can tell the team to stand down than that we miss something. But that will get you all the help you need really quickly. And more than that, it will prepare the downstream things that need to happen. Because if you see a STEMI, the quicker we unblock that artery, the better the patient does. And we are audited on the time that it takes us to unblock arteries. So we are really keen to make this happen as quickly as possible. So don't mess around trying to bleep the SPR. Don't, for goodness sake, say, oh, I think this is a STEMI, but I need to check with my senior before I bother lots of other people about it. Put out the STEMI call, get the help you need. So this patient will be rushed to our cath lab, which this isn't a picture of our labs. This is one I found off the internet, but it looks very much like this sort of a thing. And we will unblock the artery. And you might see something like this when you take the pictures. So here we have a catheter that is in our left main stem, and you have the circumflex artery, which goes down the back of the heart here with its branches. And you can see that there are bits of narrowing along lots of places here. Can you see there's a bit of narrowing here relative to a bit further down? But this is the left anterior descending artery, and this is blocked. Should be a big artery coming right the way around here. And there's this sort of cotton wool effect that's all a clot that's blocking the contrast from going down it. So you see an absence of dark contrast because contrast can't get in. So this is what a blocked LAD looks like. And a lot of damage can happen very quickly here. And it really is life-saving to get this artery unblocked quickly. We tend to go via the wrist by preference. So we put catheters that look like this through the wrist. And in the past, we used to go via the femoral artery. We don't tend to nowadays. We still do venous procedures via the femoral artery. So EP procedures tend to be done via the femoral vein, so in this location. And TAVI, when we do keyhole aortic valve surgery, we need a large artery. So Normally that's done through the leg or sometimes through the arm if we, or the subclavian and the chest and a mini thoracotomy. But normally TAVIs are done via the leg. And rarely we can't use the radial artery because it spasms and we have to go through the leg. And this is just what your normal arteries look like. So here's the big circumflex artery that we showed you before. This is our LAD and what it should look like. There's a lot of variety in different people. And this is a pretty normal looking artery, nice, clean, smooth, flowing. Here we have a tight narrowing in a right coronary artery. And can you see here? Although it's not that narrow, can you see how faint it is? And this is a tight narrowing seen at 90 degrees to this. Imagine we spin round and look at this from the side. It might be hanging by a thread in all angles, or it might be what we call an eccentric plaque, where it's narrowed across in one lumen, so it's sort of slit-like. As opposed to like an apple core where it's eaten out equally from all sides. So we have to look at the arteries from 90-degree angles, and it looks completely different as we swing the camera around and look at the heart from different directions. So this is the sort of thing we'll be looking for. Good. So we could talk a lot more about how we manage STEMIs and NSTEMIs, and the best place to go for that is if you click on clinical guidelines, and if you then search for Cardiology Handbook, you'll find the Cardiology Handbook for UHL, which is written by Dr. Hudson with contributions from all of us. And that has lots of that on how we manage a STEMI at the Glenfield. It's not rocket science. You can find summaries in lots of other places, but that will give you the details. I will do a separate talk on management of acute coronary syndromes and diagnosis and all the rest of it, but I don't want to get too bogged down in that today. One thing I will say is, what antiplatelet drugs do we use? So we use aspirin in all comers. And if they're allergic to aspirin, just be sure they're allergic to aspirin, because if we look at ISIS-2, the trial of aspirin, that was a trial of aspirin and streptokinase, the old-fashioned clot-busting drug, the one that came before the TPA drugs that we use nowadays. And that showed that aspirin reduced mortality from a myocardial infarction by 1/4, which was the same benefit as streptokinase. Combined, you got the additive benefit. So both gave, I think aspirin was 25% reduction in death, streptokinase was 27% reduction, and both together was about 43% reduction. So it's very much an additive benefit in that trial. Now, obviously, things have moved on. We haven't retested it, but bear in mind that if they're allergic to aspirin, they better be allergic to aspirin if they want to accept a 25% or deny themselves a 25% reduction in death. If they have issues with dyspepsia, then you can give them a PPI with it. The chances of a one-off dose of aspirin causing a big problem are low, but certainly you can give a PPI. If they've got a history of bleeding, then it does get a bit more complicated, but involve your seniors urgently. If we're dealing with a STEMI, we use prasugrel in preference to clopidogrel nowadays, and that has a 60 milligram loading dose, and then it's a 10 milligram once a day thereafter. The exceptions to that are if they've got low body weight or over 75, or they've had a previous stroke or TIA. So STEMIs, ST elevation myocardial infarctions, we give prasugrel unless there's one of these factors present. Otherwise, if it's an NSTEMI, so any NSTEMI other than a STEMI, any ACS other than a STEMI with a positive troponin, we give ticagrelor, which is 180 milligrams loading followed by 90 milligrams twice daily. If it's a stable PCI, so if it's an outpatient procedure, a patient coming in for a routine PCI, we still use clopidogrel, but we don't use clopidogrel unless there's a reason we shouldn't give ticagrelor or prasugrel. And you can't just switch between them without reloading. it's quite complicated how you have to switch between them because they work in slightly different ways. So if you're on clopidogrel, you can't just start ticagrelor 90 milligrams twice a day. You have to reload the ticagrelor. If we have a patient who's anticoagulated because of atrial fibrillation, most operators do the procedure on the anticoagulation. So certainly in a STEMI, you just get on and do it, but often in ACS, they do it on the anticoagulant. So speak to your seniors about that. If there's a low risk patient to hold their rivaroxaban, then fine. And sometimes we hold it and give them Clexane for 48 hours. Um, but if we're combining heparin or warfarin and antiplatelet agents, we use clopidogrel rather than ticagrelor or prasugrel. So that's the exception to this rule of using either prasugrel or ticagrelor. Good. So now you're feeling tired. It's the end of your shift, but you're called to see this patient again, and you know in your bones that you can't hand this over. You need to go straight away and see him. And he's got central chest pain again. So what are you going to do now? Yep, he's been to the lab. He's had his PCI. Everyone's been happy. I don't know why you're covering CCU as well as CDU because he's gone to CCU now, but it's you being called to see him. And despite having had his PCI, he's got chest pain again. How dare he? Yeah, so repeat AT ECG and look for signs of stent thrombosis. So I couldn't have put that really better myself. So you want to repeat the ECG. So you repeat the ECG and this is what you see. In fact, the ECG is there waiting for you when you get to him because CCU know what they're doing. What do you think of that ECG? STEMI alert again? Yeah. So should his ECG look like this? When somebody has a STEMI and has an angioplasty, what should their ECG look like afterwards? He had a lot of ST elevation before, didn't he? Yeah, very good. So every single patient who has a coronary angiogram or has an angioplasty, the moment they get back to the ward, they have a post-PCI ECG. They do not pass go, they get their ECG. And that's really important because the ECG then is what they are at baseline. So if you compare this ECG with the post-angio one, and it looks exactly like this, well, you're not happy, but it hasn't changed. And so you would want to maybe urgently bleep the cardiology registrar to assess this patient. But if this is identical to the post PCI ECG, maybe they've done their best and they've just not been able to get very good flow down the artery, or it was too late and a lot of the damage has already happened. And this is his residual ECG. So look at the post PCI ECG. Here, this extent of ST elevation, if you're not sure, you don't know, you can't find the ECG, this is a STEMI caller, absolutely. He's reinfarcting, he's got stent thrombosis, highly likely, you're absolutely right. So don't mess around, but if you're in any way unsure, is it significant or not, look at the post PCI ECG because there will be one and you're looking for dynamic changes. So this is a scenario where you will be the first person to see the patient and spot this. So important to know what to do. This is a patient who's reinfarcting. They need to have another STEMI alert. And so he goes, it is found to be stent thrombosis. They unblock it again. And this is his ECG post repeat coronary angiography and repeat unblocking of that LAD. What do you think about that ECG? Yeah, so this is a very bad ECG. There are QAs in almost every lead. There's poor R wave progression. There isn't any real R wave, is there? So this is a very unfortunate patient who's lost the entire front of his heart and some of the back of his heart as well. This patient has had a massive infarct, and stent thrombosis is devastating because very often when patients have STEMIs, it's a dynamic situation. The clot forms, it resolves, you get a trickle of blood through. It's amazing what good stuff blood is. Even a little trickle can keep the territory alive. Um, if it blocks completely, and the stent thrombosis is usually a complete block and doesn't dynamically open and close, then a massive amount of damage can happen even in half an hour or two or so. So stent thrombosis is really devastating, really bad news, and that's what in this hypothetical scenario happened. In actual fact, this is a case from the days when I was a junior doctor and I was thrombolizing patients, and this is a patient who failed or who initially thrombolized successfully and then reinfarcted and didn't benefit from a second dose of thrombolysis. So this is what happened sometimes before we had PCI. It's very rare to get this scenario if you have PCI, very rare to see acute stent thrombosis, but it does happen. And please, if it's on your watch, spot it and urgently involve the team. And this is the reason why it is so critical that patients take their antiplatelet drugs post PCI, because if they don't take them, the chances of this happening and a devastating infarct happening is high. So if a patient goes off and has a GI bleed and then has all their antiplatelet drugs stopped because, my goodness, the GI bleed's a bad thing, well, this is what can result from that. And the decisions about antiplatelets can be really tough in that sort of situation. So this patient has unfortunately not done very well. And so next morning when you come on shift, you go to see him first thing, and you find him to be unwell. You find that he's peripherally shut down and hypotensive and tachycardic. What are you thinking? Yeah, so cardiogenic shock, that certainly is seems likely, doesn't it? Given how much damage he's had, he's could well be going into cardiogenic shock. Any other possibilities? So I'll come back to that in a moment, Susanna. Tamponade, yes. So tamponade can happen with myocardial rupture after this sort of big infarct. It can happen because you have a perforation. The wire that we put down the artery to put the stent over can actually go through the um, coronary artery, and a little hose of blood can go out that hole in the coronary artery and slowly fill up the pericardium and cause tamponade. Not usually the next morning, but often on the ward after the procedure. So tamponade always consider in this scenario. Anything else? Yeah, you could have a VSD, a ventricular septal defect. Good. You'll hear a loud murmur if that's happening. And Susanna's excellently pointing out about retroperitoneal bleed. So ask and have a high index of suspicion for this. Um, Find out if it was done femorally or not. If it was done through the femoral artery, then it could be a retroperitoneal bleed. If it was done through the radial artery, clearly it won't be. The problem with going through the femoral artery is you can't, if the puncture is slightly high, which in overweight patients it's easily done, then sometimes you can bleed backwards into the retroperitoneal space. And that often doesn't show up early. And it's only when the patient becomes hypovolemic because they've lost a couple of pints of blood into their retroperitoneal space that you realize what's going on. And they might have really very mild abdominal pain and mild symptoms, and you need a really high index of suspicion for this. We have about maybe 3 of these a year. So statistically, one of you will be the first person to assess this patient. And they might not be as spectacularly sick as this patient. Often they're post-TAVI when we do, that's the most common femoral procedure we do nowadays. And they might have relatively mild symptoms of being a bit tachycardic, slightly low blood pressure, just not quite right, and mild abdominal pain. They often don't have a lot to show for it in their groin where the puncture site was. But unless you consider retroperitoneal bleed, the problem is by the time the patient's properly sick and they call somebody more senior, it will be too late for the patient. So do always consider retroperitoneal bleed in patients who've had femoral procedures. There are lots of other things that we should be concerned about here. So it could be, as we've said, the heart failure. We've said about VSD. It could be acute papillary muscle rupture and severe mitral regurgitation. We could have, I've said the patient's tachycardic, so it's unlikely they've got a bradyarrhythmia, but that's common post-infarct. They could be having VT or just AF, and that's decompensating the patient. Patients with big infarcts can get a ventricular thrombus. That is asymptomatic until it goes somewhere, but that's something to be aware of. That might need anticoagulation. Ventricular aneurysm forms much later. That's a late post-infarct complication. Pericarditis is generally something which occurs later, but that would be a cause of ongoing chest pain a few days after an infarct or a month after an infarct if it's Dressler's syndrome. The other big category of things to be aware of is GI bleed. This patient may have developed a stress ulcer from the presentation. We've given them a lot of blood thinner medications. So think about your post-infarct complications, and the big things that I want you to think about are the retroperitoneal bleed, arrhythmias, and gastrointestinal bleeding, because that's a big one to exclude. If the patient's got a ruptured their VSD or mitral papillary muscle, then that's bad news, and you'll know about it because you'll hear a very loud murmur when you listen to their chest. So that's not something you need to really worry about remembering. Thinking, could this be a GI bleed or a retroperitoneal bleed in your mildly unwell patient with a bit of abdominal pain and slightly hypotensive post-procedure? That's very important. Retroperitoneal bleed, as I've just described, if you're slightly high in your puncture, because there's nothing behind the artery, you can't compress the hole. And so you can bleed backwards without knowing anything about it into this retroperitoneal space. And you check up here and all looks well. You can do a CT scan and see this huge clot is developed, this huge bleed in the retroperitoneal space. And as the tissue's torn apart by the blood pressure, this starts to ooze, the capillary ooze you get because you're on loads of antiplatelets, so none of it clots. So this becomes a self-perpetuating thing, even if you stop the cause of the hole, because you continue to ooze around here and you can't stop the drugs because they'll have an infarct, and it's just horrendous. And these patients end up on ITU with massive transfusion reactions. Really, really hard to survive and bad news when it gets to this point. But if you can spot it early and we can get there when this clot is, a quarter the size of this, then this vascular surgeons can just put a covered stent in and the problem can be very, very fixable. So it by the time you have bad symptoms, it's too late. Have a high index of suspicion for a retroperitoneal bleed. Good. So in the last 10 minutes or so, I want to cover other complications for you to be aware of. So imagine that you're on call and the patient or on the admissions ward, or your patient on your ward has been for a procedure, and they've been either for a pacemaker or an EP procedure. We'll talk about specifics of each, but imagine it could have been either at this point. And they've collapsed with low blood pressure and confusion on the ward afterwards. So what are you going to do about it? What's going on? What are you going to do next? So do your A to E, very good, A, B, C, D, E, and then consider an embolic cause. So you're thinking about a stroke, and a stroke is a recognized complication of an EP procedure. Very good. With a suggestion of a tension pneumothorax, absolutely, that could happen following a pacemaker, hopefully not with an EP procedure. Very good. Anything else? So you've gone through your A to E. What are you going to do next? You'll imagine this patient's in front of you. They're, really not looking great. What are you going to do? It could be tamponade. That's a really important consideration. Following any procedure we do in the lab, basically can cause tamponade, and that is a really tough situation often to diagnose. So tamponade, absolutely consider in any patient like this. Very good. I think that's probably the most common, really serious thing. So what are you going to do? So far, we've got A to E, but before we know the diagnosis, you're going to do some further tests. You're going to look at further things. What else are you going to do? Yeah, ECG, very good. Get an ECG done. So if they've had a pacemaker, maybe the pacemaker lead's fallen out and they're in complete heart block. Maybe their EP procedure has caused complete heart block. Absolutely do an ECG. Bedside echo, yes, somebody's going to want to do a bedside echo. We want to do a portable chest X-ray, very good. Any other simple things that you can check for a patient who's been for a procedure? So yeah, we could think about certainly we want some bloods and possibly a blood gas. Um, so check their blood sugar. Whether or not they're diabetic, they've probably been starving for the procedure. So check their blood pressure, their blood sugar. And also consider, have they been sedated? Because we often give patients sedation in the lab, and often the adrenaline keeps them awake while they're in the lab, but then they finally relax when they get to the ward, and then suddenly the sedation kicks in and they become confused. So maybe they've been over sedated. Make sure you consider the low blood sugar. Um, the best person to get involved in a patient like this is the person who did the procedure. Now, the caveat to that is that they might be unable to leave the procedure that they're doing now, but often one of them can go to the ward. And if I've got a complication of one of my procedures, I would like to be involved in how that patient's managed. If you can't get hold of a cath lab person, then get the cardiology SBR on call. How do you get hold of the consultant who's doing the procedure if you're a bit scared of them and you're just a bit nervous about going to disturb them? Well, speak to the cath lab coordinator. They will be much more confident than you in interrupting a procedure to say, look, one of you guys needs to go to the ward and just check that this patient's okay. And you can do simple things quickly, but if that patient is really looking poorly, they could have tamponade, and if you wait 10 minutes to see if they're going to look better, then it might be too late. So don't hang around. Get the cath lab person to do it or the SBR on call to support you. There are lots of different things. We've covered some of them. Um, the important ones to remember are things like well, I do think all of these are things to be aware of, but the most common cause is a vasovagal episode. So often, just the stress of the procedure and the fact they've been nil by mouth, when they get back to the ward, they finally relax and they have a vasovagal episode. So mostly these patients are much better if you just lie them down flat, raise their legs, and give them some fluids. So do that to temporize while you're trying to work out what's going on, because you can't really go wrong with that. Um, but consider that there could be some other more serious causes that you need help to diagnose. Good. So that's all I wanted to say for today. Please, I'm very happy to answer any questions. I do these talks pretty much every week. Unfortunately, I'm on leave next week, so it won't be a talk next week. But other than that, there will be a talk basically every week. So please attend. Please give me advice about how I can improve these sessions for you. I'd be very happy to change what I do if you feel that I'm getting the balance of this wrong in any way. Feedback is always helpful. I've just posted a link in the chat. That's to a very short form. If you fill out the form, you can have a certificate to say you've attended, and there's a little bit of quick feedback for me, so please do that. I have been recording this presentation, so I will upload it to the YouTube channel, and you'll be able, if you scan this link, to get access to the YouTube channel. Anybody can access it. That's the link, but just the QR code will put that into your phone. And you're welcome to subscribe and watch any of the teachings. So hope you join me in 2 weeks' time. I hope you've enjoyed your first few days at the Glenfield and been made to feel welcome. Thank you very much for listening. Were there any questions before I sign off?